And also when you look at the pre-qualification process, WHO was able to list actually lenacapavir as a priority product even before it had been approved by the the major regulatory bodies. So what lessons is being picked from here? It is to say that we are learning from this process that actually the processes can run simultaneously, and it helps fast track or fast track the processes of even preparing the market, preparing implementation, preparing policy and decision making to a point where you eventually use it in country. And I'm sure it is evident for lenacapavir. We were very quick to really adapt it as soon as it was granted an approval. And this is just the lenacapavir story from an implementation perspective. When the PURPOSE 1 and PURPOSE 2 results were released in October 2024, immediately WHO listed it in the expression of interest list for products for pre-qualification. Like I said, this is a process. First, you have to have the approval take place first before you list a product for expression of interest for pre-qualification. And as you can see, before the end of in October is when the product was actually pre-qualified, and this came after the guidelines was developed and the process, just to appreciate that this process can run parallel, and we're learning from the lenacapavir implementation. So Kenya is among the 10 countries that have regulatory approval in Africa to implement, and many thanks to the goodwill from the political arm of government to really make sure that the uptake is catalyzed and as fast as possible. So I think this is quite commendable, and I know most of us have launched the lenacapavir in our respective counties. So this is for us to appreciate the regulatory approval process, and the focus here is on Kenya. We had this product approved at the beginning of the year, which then ushered its way to ensuring that we all have the products in our respective service delivery points. How is the supply looking like? The supply is, I mean, we know that we received our first consignment in March. I think the Ministry of Health is best placed to speak to this. In March, we received adequate doses, and then of course expecting another consignment in August, and with the support of Global Fund, PEPFAR, and other institutions, Kenya is among the 4 countries that launched lenacapavir in sub-Saharan Africa. So what are the key takeaways? The key takeaways, and I'm wrapping up, is lenacapavir is 6 monthly injection, is found to be very safe and highly effective in preventing HIV. It can be used very safely amongst basically in everyone. Everyone can use it: adolescents, transgender people, people who are pregnant, and lactating mothers. And also there is, I mean, there's been reported, you know, cases or incidents of nodules that as a result of the injection at the injection site. And then it's coming fast in the market, and we need to keep up the momentum so that we scale up its use. And of course, we hope that before the end of, by August, we'll have the second consignment to boost the pipeline for subsequent scale up. So what is again coming up, and I think Wawira was one of the panelists who speak to this, is that there's the horizon is promising. There will be generic lenacapavir coming up, and the processes are being fast-tracked. So we need to really act very fast to make sure that everyone who needs benefits from lenacapavir. Thank you very much. I acknowledge all colleagues who participated in the development of these slides, including Wawira, who supported the process. Asanteni.
Thank you, Dr. Eunice, for taking us through the global context. I'm going to take us through the Kenyan context. Good afternoon. Thank you so much. Now I'm going to take us through the Kenyan context of PrEP or prevention. Now, Kenya has made significant progress in testing, treatment, prevention, and prevention remains key to sustaining the gains made. Yes. Thank you for that reminder. Very important. Uh, I'm sure we had made arrangements for somebody to do the interpretation. Justus, you can give us an interlude as we
Okay. Sorry about that. And allow me to also pass our apologies to our community members who are here with us today. That was an oversight. I believe the interpreter was here in the morning and maybe stepped out, but will be joining us. We have agreed on modalities. We're going to send the slides, and we're going to make sure that they also get caught up on the session. So my sincere apologies from the planning team. That was a big oversight. So with your permission, can we proceed? We can? Thank you. So Dr. Jonah, please. Asanteni sana.
Thank you for that. Apologies once again for that. Yeah. So I have 10 minutes to go through the slide deck. And as already mentioned earlier, my name is Jonah Onentia, working with the NASCOP. As I had said, in terms of, as a country, we've made significant progress in terms of HIV testing, the prevention and treatment. And prevention still remains a priority to sustain the efforts already made by the treatment program. The new infections have reduced significantly by 80% since 2013, and showing great progress, but we still need to do more as a country, including collaborating with all the stakeholders, including with our all the communities and all populations, and leaving no one behind. The data shows that new infections are concentrated, geographical specific regions, and also specific populations. The integration of HIV prevention into other health service delivery points is also one of the main approaches as a country we are using to ensure that there is increased coverage and sustainability of the HIV prevention efforts. In terms of epidemiological context, this is where we are as a country. In terms of the total PLHIVs, we are at 1.326 million, and of which there are 62,798 children living with HIV. And 60% of the people living with HIV are within the age bracket of 30 years to 54 years. And as you can see, the national prevalence, HIV prevalence in the country is 3.0%, with a bias of the prevalence towards the female gender at 4.1%, and the male population is at 2.0%. As we said, that the concentration of the HIV infections are concentrated in some geographical locations, we can see from this slide that we have about 50% of the PLHIVs living within the listed 7 counties from Nairobi, Kisumu, Homa Bay, Migori, and Siaya, Kiambu, and Mombasa. In terms of the HIV prevalence, the trends, as you may note from the slide, is that we have been coming down from a high of 6.0% to about 3.0% at the moment. So there's been that gradual decline in terms of the HIV prevalence, thanks to the HIV treatment and HIV prevention programs. Still on the new HIV infections, using the HIV estimates 2025, this is where we are. As you can see, we've already said that the HIV prevalence is concentrated between the ages of 30 years to 54 years. And as you can see, there is more bias towards the female gender at higher numbers than compared to men within the equal, within the same age bracket. Of significance also to note is that 41% of the adult new HIV infections occur among the adolescents and the young persons aged between 15 to 24 years. In terms of identification, remember we have identified 98% of the total PLHIVs, and in terms of linkage to treatment, we are at about 98%, and in terms of viral load suppression, overall, as a country, we are at 94%. So in terms of the UNAIDS 95, 95, 95 cascade, we have achieved 98, 98, and 94%. However, geographic population-wise, we can see that we are still lagging behind in terms of children identification, where we are performing low. That is 58%, and 54% viral load suppression. As a country, what has helped us to achieve the gains that we have achieved so far is the element of combination prevention. That is the lens that we are looking at. And within the biomedical prevention, we have all those efforts, interventions, and strategies, right from PEP, PrEP, VMMC, EMTCT. Under the behavioral interventions, we have abstinence, ABC, and then the risk reduction counseling. We also have putting more emphasis around structural interventions, looking at enrolling and retaining all the AYPs in schools, and efforts towards economic empowerment in the communities. For the purpose of this session this afternoon, we are going to look at just one of the several modalities that are under the biomedical interventions, which is PrEP. And PrEP in this case is offered as an additional choice to the several intervention strategies within the combination HIV prevention space. In terms of the journey towards where we have reached regarding the PrEP, this journey started in 2015, and where there was the WHO recommendations and the PPB approval of the oral PrEP. And in the country, the launch was in 2017. And then what I want us to also appreciate is that the interval between the approvals, if you compare the oral PrEP and the amount of time that it took between the approvals and implementation in the country, because of the evidence that is coming out, that duration is shortening, and we were able to see that from the global perspective, the presentation that was given earlier by our WHO counterpart. And in the year 2021, we had the DVR approval, that is the dabivalent ring approval. And in the year 2024, we also had witnessed the cabotegravir long-acting approvals being done by the registration or the regulatory body, that is the PPB. And in the year 2025, we had the registration of the lenacapavir by the PPB. As you can see, the period of registration is getting shorter and shorter, and therefore as a country we are able to get several options that we can be able to offer our clients. In the country, the recommended PrEP regimens include the daily oral PrEP, which can be as daily for the 1 month, or the event-driven oral PrEP. And then we also have the cabotegravir long-acting injectable, and we also have the lenacapavir injectable that is out there in the facilities. The daily oral PrEP is taken as daily. It can be taken with or without food. And then the event-driven is the 2 pills, 2 to 24 hours before sex. That is 1 pill 24 hours, 1 pill 48 hours after the loading dose. And then the daily dosing risk, if the risk is more frequent than 2 times per week, and the activity or sexual activity cannot be predicted or delayed by 2 hours. And then the cabotegravir, we have the molecule being administered on the gluteal or thigh muscle, and it is not recommended for initiation in pregnancy or breastfeeding, at least in the country. And then for the lenacapavir, we have the molecule being administered as subcutaneous injection in separate areas in every 26 weeks. That is roughly 6 months, with a plus or minus 2 weeks for the TCA from the date of the last injection. The injection sites that we've adopted as a country include the abdomen, and then the anterior thigh or the posterior upper arm. It is safe to use during pregnancy because I'm sure that is one of the concerns of the healthcare workers out there. So what we want to say, it is safe to use during the pregnancy or breastfeeding period, and also patients with severe renal disease. In terms of the milestones, if you compare those two commodities, that is the long-acting molecules, both the lenacapavir and cabotegravir, in terms of approval and dosing interval, lenacapavir is injectable every 6 months, and cabotegravir is injectable every 2 months. And then the rollout plan, we have starting in the 15 initial counties, and targeting facilities that are serving the general population, the AYP, the key populations and the vulnerable populations. And ultimately we want to scale it to all the 47. So the first approach will be done in 3 phases. All the 2 drugs are available in the country already, and they have been distributed to the phase 1 counties, and we want to look at how to transition to the phase 2 counties. So the PrEP expansion plan overview, we want to deliver the lenacapavir and Cab-BELE as an additional PrEP options. Remember, we are not pushing, as a country, we are not pushing any particular commodity as superior to the other. All we are saying is we are taking it as an additional PrEP options. And these are the counties that are listed in the phase 1, phase 2, and the phase 3. Already the drugs or the commodities are in about 10 facilities in Kisumu, Mombasa, Nairobi, Migori, Homa Bay, Siaya, Kisii, Kajiado, Busia, Machakos, Kiambu, Uasin Gishu, Kakamega, Nakuru, and Kilifi. Already we have about 10 sites within those counties that the commodity can be received or can be offered. And I'm sure the IEC team is doing a lot to make sure that everyone in the society knows which are these 10 facilities. In terms of the update, the rollout update, we have managed to do the trainings, and we have also managed to do the national launch, which was done on 26th of February 2026, spearheaded by our Cabinet Secretary for Health in collaboration with other stakeholders. And this was done at Triruta Health Center. The principle of the many options that we have is that the options alone are not choice. So we are delivering the PrEP options through the PrEP choice counseling. And the options refer to discrete HIV prevention methods available in a specific market. So for example, in our country, the options that we have are 3. That is the Cab-BELE, oral PrEP, and lenacapavir. And then the choice is the autonomy, knowledge, and freedom from coercion at any given time to select the best method for them among options available. So what we are training our healthcare workers is to be able to give the necessary information for the client to make the informed choice. So the principle that we are applying is PrEP choice counseling, and we are not in any way pushing one commodity as superior to the other, because we know of the merits of each and every molecule. So some of the known barriers that to accessing PrEP have been the stigma, then lack of provider empathy, lost income, getting services time consuming, ESOL, and also looking at the long distances that one has to travel to get there or to seek the service, and also the long waiting times, the lack of privacy, and the limited hours of operation of some of our public facilities. So based with these barriers to oral PrEP or PrEP administration, as a country, we are now collaborating with other stakeholders, both the community, implementing partners, development partners, so that we can be able to see how best we can be able to diversify the various models of PrEP service delivery, so that even those who will not ordinarily receive PrEP within our brick and mortar facilities, we have a way of being able to reach them. And therefore, we are coming up in collaboration with our implementing partners, donors, community, so that we can be able to come up with innovative PrEP delivery models. And the goal for this is to make PrEP easy and fun to try, and also hard to avoid. So PrEP effectiveness depends on providing easy access for those who need prevention, providing a choice of product and delivery models so that we can be able to bring as many clients on board, those who need PrEP, and they have to be taken through the criteria for assessment on risk, and also ensuring there is sustained use. So how to innovatively deliver PrEP, we want to look at through the private sector framework, partnering with the private institutions so that we can be able to have that collaboration between the public facilities, the private setup, so that we can be able to deliver PrEP or any other prevention modality through the private sector. We're also looking at the pharmacy delivered option or model, which can be either online or the brick and mortar community pharmacies. And also looking at partnering, collaborating with peer-led activities so that we can be able to have the right information out there in the community so that we can be able to drive the demand, and also make sure that the correct information goes out there. And then integration with other service delivery points. We are partnering with SRH team so that we can be able to have the commodities delivered within those sites. And then using the mobile PrEP delivery options, and also the digital PrEP, tele-PrEP, so that we can make it as easy as possible to pass the information, conduct the counseling sessions, so that we can be able to shorten the time with which it takes for one to get the service. So thank you so much. That is what we have to deliver as a country, but I know as we interact, we'll be able to share more information on the same. Thank you so much.
Okay, so thank you so much for our two presenters. That is Eunice Omesa from WHO and Donna Onentia from Ministry of Health. They gave us the framing presentations, just trying to outline what the science is behind LEN, what the global guidance is, and what Kenya's plan is for our HIV prevention and the scope. So now we want to quickly switch over. I thought Justus was in the room. I think we have lost him. Now we want to quickly switch over to our panelists. We're going to try and make up for time as much as possible. So we want to do a panel discussion now with, I do not know whether this, is it going to show the panelists up? I want to see the panelists on the screen so that we can start inviting them up, please. So one by one, I will start by inviting our moderator, that is Patricia Jekonaya from LVCT. Please give her a round of applause as she comes up. I think her profile should be somewhere up there, but then we will hear more about her. After Patricia, I would like to invite Dr. Dan Were from Japaigo. Please come up. Dan Were. A round of applause, guys. I know we have more participants outside than inside. Then we have Solomon Wambua. He's from the KP Consortium. Can we have him coming up? We have Mr. George Kissinger. He's from Mombasa County. He's the VTP focal person. And as you see the people who are coming up, you will understand what the kind of direction we want the discussion to go. And then, what? Then we have our latecomer, our most serious donor, all the way from Geneva. Please come up, Jackson. Jackson Hungu is going to come up. A round of applause, please. One of the reasons why we have Len with us today. And then we have a PrEP community champion, that is Samson Mutua. You may have seen him on media. He was the first brave Kenyan to receive the injection, the lenacapavir injection. So I believe this is all of us, and I will hand it over. Prof. Ngure, sorry, Prof, please forgive me. Prof. Ngure, he is Associate Professor of Global Health. I think he's the incoming president for IAS, and he's also here to speak about the science. So this panel is supposed to be interactive, have questions and answers, and then we will hand it over to all of you on this side to be able to ask questions and answers. Okay, over to you, Patricia.
Right, thank you so much and welcome to this very exciting panel. We want to make sure that we are asking the right questions, but also at the same time invite you to start thinking about any question you may have about lenacapavir or any of the long-acting products. So thank you, Dr. Barbara, for the great introduction, and I know we have just clapped for Samson Mutua, but I think what he did was very courageous. Do we all agree? So I want us to give him a very organized clap, because I'm sure that day he decided, I'm going to go for this, very organized. So let's give him a 3 factorial, and in 3, 2, 1. There are people who failed mathematics. Murudishiwe nini, school fees, part of it. Yeah, but thank you so much. And I will just start with Samson, because I'm sure all of us would really love to hear, what was his experience and what made him, go and take up or rather use PrEP. So Samson, if you could please just share with us what that experience was like, and what made you decide to use PrEP?
Good afternoon. Am I loud enough? Am I clear enough? My name is Samson. I'm a community health promoter. As you saw, I was a QAP educator for PhD. So what happened, my story starts from long ago. My story is sort of a little bit sad, but it's okay because it has led me here. So basically, while I was in high school, I was in a day school, and it was located in almost the middle of the CBD. So I was how can I put it? I was so nilikuwa inakata kukuja. I'm sorry guys.
It's okay, just breathe in and relax.
I was exposed to a lot of things. Our generation, tunajita generation Gen Z, we're exposed to a lot of things compared to the previous generation that came. We have a lot of dynamics that are changing. So while I was in high school, na hizi experiences zangu mingi, it led me to several activities zenye naweza sema zilikuwa responsible activities, and this was mainly because of lack of information. Because you find we are given condoms, we are distributed condoms, but you are not taught how to properly use it. I would just like to ask a question, like a man who knew how to properly wear a condom before he was 20. Raise your hand.
A man.
A man who knew how to wear his condom properly and dispose it properly before he was 20 years. Raise your hand. Tuko wengi. So this is one of the factors. So what happened, because of this lack of information, I found that I was prone to sometimes condom bursts. Yes, I want to protect myself, but I don't know how to use it well. I have found it, I have gotten it from an institution, but I don't really know how to use it well. So I was in and out of PrEP for some time, and then a certain day I just received a phone call from my friend. He was asking for blood appeal because his father was admitted at the National Hospital. But apparently I was so afraid. I was so afraid to go and donate because I didn't know about my status and I hadn't tested. And because of all these dynamics, all these behaviors, I was so scared. So I didn't go to donate blood. I had to seek other friends to come and donate blood. But this was a fear. This became a fear because I'm already pressured. I don't know my status. Something has happened. Somebody didn't receive help because of what I was afraid of. So after that, after my father's friend got the blood and everything was well, I was passing somewhere through Kibra, and then I found an institution which was testing. I got tested. And I got cancelled. After getting cancelled, I told the counselor, of which is usually very hard. For youth like me to come and open up to someone who's older than me, maybe for the age of my father or my mother, it is so hard. I won't tell you the truth, by the way. All youth that are here can say it. They won't tell you the truth. They won't. So I spoke out, and I was counseled, and then I later come to learn about PrEP. After learning about PrEP, that was on 2017, I started taking PrEP, but I was on and off. But I came to realize that PrEP is not really a burden pill. If you come to think about getting infected and you have to take the pills for the rest of your life, you see, PrEP is not a burden pill. And then now we are here. Yeah, we are here. We are here at Lenacapaville. Yeah, it's protection for 6 months, but it doesn't basically give you the right to just go and do whatever you want. There is a lot of miscommunication and misinformation. Anybody in the audience can just take a phone and you just type up Samson Mutua in Google, and then you can just read. We are doing a youth forum. We're integrating this health with the youth. We want a healthy future for Kenya. As youth, we are the future for Kenya. But you can see what already they are speaking. So like that is your community. Whatever you read there, you just know that is your community. And whatever it's being typed there, it's due to misinformation. And that's why we are in this forum right now. Thank you.
Great, thank you so much, and for that emphasis that there is more we need to do in the community to make sure we have the right information. But maybe just one question: did you experience, and if you're free to share, any kind of side effects or something not pleasant when you got the injection?
Actually, before I got the Lenacapavir injection, I was trained. I was told what to expect. So I didn't get anything more than what I was told to expect, because the pain kama kawaida kidungwa shindano inakuanga hapo. It's 2 injections administered. Mmeona pale inakuwa administered. Mimi nilikuwa administered at the abdomen. So it wasn't what happened is what I was taught, what I was trained, and there is nothing else. I know there are a lot of speculation. Kuna mpali mtu atasoma nimechizi, kuna mtu alitype hapo nimechizi. But you guys can see I don't even need counseling, because after the training I know that HIV has been with us for 40 years, more than 35 years, and until we are here at Lenacapavir, it means that it has taken more than 30 years of development on HIV research for us to get at where we are right now.
Asante sana. And by the way, Samson is also a community health promoter. Okay? I would like to ask Prof. Ngure. We've just heard about Purpose 1 results, and probably just to hear from you, what safety monitoring systems were put in place to detect potential maternal or fetal side effects, or to transfer LEN into breast milk, and implications of infants. And why this question is important is we've all seen our PMTCT prevalence at about 9.1% when we should be 5 or less. So what does this mean for our prevention?
Thank you, Patricia, and good afternoon, everyone. Great to see very many friends in the audience, and I'm happy that we are having these conversations, especially around REN and around use of these products during pregnancy and breastfeeding. I think we need to take a step back and ask ourselves, why do we need to have these products used by pregnant and breastfeeding people or women? The reason why we want women to use these products when they are breastfeeding or pregnant is because studies have shown that they are at very high risk of HIV acquisition, mainly because of biological factors, especially around pregnancy, but also behavioral factors. And most of the studies that have been conducted have left pregnant women and have left out breastfeeding women, yet they are among the highest risk groups. And the clinicians in the audience will agree with me that also when women acquire HIV during pregnancy and breastfeeding, there's also an increased risk of mother-to-child transmission. So this was a group that has always been left out. But thankfully, In Purpose 1, they did something different. They allowed women who became pregnant to continue with their product if they chose to, and when they went to the breastfeeding phase, they allowed the women to continue getting the injections. And what happens in this kind of trials when you do that, then you have a sub-study, a sub-component where you offer additional monitoring for the pregnant women and the breastfeeding women. And this includes just looking for adverse events, side effects, what we call side effects. You look at them during pregnancy, you have OBGYNs or doctors looking at them during pregnancy and also during breastfeeding. Once the baby is born, the babies in this specific study were also followed for 12 months. But what they do, because people still get unwell, pregnant women will feel bad, will get a few challenges. When babies are born, there are also a few challenges, is that in this specific study, Purpose 1, they were comparing the women during pregnancy with those who are in the other study arms, that is the Truvada arm and also the TAF arm. And they were comparing the side effects there, and then once they got the babies, they compared the babies throughout. And what was learned is that lenacapavir was safe. So it can be used during pregnancy and breastfeeding. That's a take-home message. The other take-home message is, many times when you have a drug, it also goes to the breast milk, and then from the breast milk, it goes to the baby. So there was also a small study that was looking at those components. It looked at the amount of drug that went to the baby, that went to the breast milk first, which was a small amount, but even what went to the baby was like 2% of what the mothers had, which is minimal, as compared to what would happen if that baby got a vertical transmission. If that baby got HIV, there would be a real problem. And that very small amount did not affect babies in any way. So it's reassuring, and that has informed the future studies that are going to happen, which I'll probably talk about later, in terms of how to engage pregnant and breastfeeding women instead of waiting until after the study is conducted, then you start doing additional work around pregnant and breastfeeding women. Maybe I could pause there.
Great. Thank you. Thank you so much. I want to turn to Dr. Were, who's seated right next to me. And they have done some great work in the country, looking at the community and the pharmacy-based delivery of oral PrEP. So, Dr. Were, if you could share with us some of the lessons about the potential of the pharmacy and community models to expand access of PrEP beyond the traditional health facilities.
Okay, so thanks Patricia, and thanks everyone for this opportunity. I think we have worked this journey from 2016 when we began the initial introduction and rollout of oral PrEP in the country. And I must say right now, the point where we are, there are lots of useful lessons to guide us thinking forward. Because the initial journey of oral PrEP rollouts, I would say, was more of building a ship, really as you sail, experimenting with different service delivery models. And initially we did try out integration within CCC, but then diversified that to several other points within facilities, to OPD, MCH, FP, and different delivery platforms, but also tried out quite a lot of community models, initially with the key populations, DICEs, outages in hotspots, worked in safe spaces to reach out adolescent girls and young women. And I must say that each of these different delivery models, I think, have a place as we talk about choice of where to deliver services, because in the context of differentiated service delivery, when you think about who delivers the service, where the service is offered, I think each of these points has a role to play. But also importantly is that the evidence has shown us which delivery models are preferred by which populations. Because for instance, from 2016 to around 2021, when we supported initial PrEP scale-up, back then through the Gilindo project, we did see that about 80% of the almost 40,000 initiations that we saw through that project came largely through drop-in centers and community outreaches as preferred delivery platforms. Certainly for some of the delivery models like outreaches, services had concerns about sustainability and cost considerations, but certainly we saw those were preferred models. From 2022 to date, we have moved beyond that to look at opportunities in the private sector. And here we have tested two models. We have tested an online delivery model, but we've also been able to pilot PrEP delivery through pharmacies. And I think some interesting insights and lessons from these models. One is really there is high demand for services in these areas. I think these are low-hanging fruits where many people frequently seek other sexual and reproductive health services, but had not been utilized for PrEP delivery. So we are seeing a lot of high demand for services. I think the other question was a concern about displacement, whether we are displacing people from the public sector to the private sector. Surprisingly, about 90% of people who are coming for PrEP in these pharmacies, for instance, are actually new clients who are PrEP naive. We also did try out a referral model where people came to pharmacies, were referred to seek services in public facilities, and followed up after 3 months. And what we saw, interestingly enough, is that more than 80% actually didn't go to the public facilities. So essentially it tells us that some of these models are actually expanding the pie rather than displacing what we are seeing in the public facilities. And lastly is that essentially there's also the opportunity for reaching out to demographics like men who ordinarily we don't see seeking PrEP services in some of these other delivery platforms.
Right, thank you so much. I think that input is quite critical as we are thinking about lenacapavir and the Kabele and all these other products as they come. Where do we place them? Where do people want to access? Sometimes it pushes us to go out of our comfort zone of just taking them to the facility to start partnering, at community level. And I want to ask a quick question to Solomon before we hear from the county. So Solomon leads the Key Populations Consortium, and I'd like Solomon just to speak about KP programs that have been at the forefront of PrEP implementation in Kenya, and what service delivery approaches have been most successful in reaching key populations. And I think as you talk about that, you could also just link it with the current status of things, in the country. What potential service delivery approaches could actually work? Thank you.
Good afternoon, everyone. I am Solo from the Key Population Consortium, and do we all know who key populations are? Yes. One. FSW, that is female sex workers, that is one. Two. MSM, men who have sex with men. 3, TG, transgender community, and PWID, persons who use and inject drugs. Yes, as per the HIV response. So I do coordinate the communities of key populations, and what we are actually seeing right now in terms of service delivery is, yes, we have the drop-in centers, which are actually led and run by key populations. I think for us, that works best because we know the actual way to do it. And as key populations, we have seen that work. But come the stop work orders, we saw actually now us get cuffed a little bit, yeah? We saw actually peer educators who are the cornerstone of our HIV response. Some actually go home because peer educators were seeing that they were not needed. Yeah, but then we actually say there is a flaw in terms of the programming. So as of now, currently, we only have peer educators who are supported by Red Cross. So programs that were supported by PEPFAR, that is through USAID and partly CDC, do not have peer educators. So that calls for a gap in terms of response. And then as we continue with the response, I think for me, it's looking forward. How do we actually now discuss about platforms of integration? We are here actually saying that as key populations, we don't wholly support the theme about integration. But can we first of all have transition, right, of programs, whereby we are looking at different models, whereby key populations come, the government comes, and then we can actually get that, should I say, that model that best works. And this is just a presumption that these are the counties, or it is in a county whereby we have key population programming or key population-led programming. We have counties that do not have key population organizations. Can we also think about such counties as well? You know, and I think for us being here is how best we actually create that model, and I know that process is going on. So follow us within these 4 days. We will actually continue building that sport. And then lastly, I believe for me it's looking at the new opportunities that even LEN poses to us. You know, looking at the new opportunities that we have in counties in terms of share engagement. What are some of the opportunities that are there? And I believe as key populations engaging in this platform, definitely will give a response. Thanks.
Great, thank you so much. So the idea around co-designing, rather co-creating together with the key populations to see what approaches can work. All right, so we'd like to hear from the county. This is where everything happens. As at national level, all the policies are done, and then all the headache is thrown to the county. So we'd like to hear from Kisinja, who is from Mombasa County. So if you look at the county health systems, what opportunities exist to integrate PrEP delivery into maternal, child, and also vertical transmission programs? But having listened also to Solo, what are some of the things that are being done to ensure that key populations also continue to access services?
Okay, thank you for the question. Kisinja George is my name. VTP focal person from Mombasa County. What we've done, and we realize that MCH becomes a critical area in terms of access to women. So the first thing that we've done is to leverage on the existing. In terms of expanding, already we're targeting with the EMTCT program, we're targeting positive mothers. So it's just to also have an additional service package for the women who are HIV negative. And this one calls for purposely in terms of screening who are these HIV negative women at high risk. And what we've done is having the lay service providers, that is the HTS providers, having screening and also conducting health education on issues of PrEP, and also referring eligible clients to the nurses within the MCH that they're able to prescribe and also initiate. The other thing is we have sites that would be talking about the EHTAs, and from the EHTAs, from some of the questions, then we are able to probably from the machine learning identify women who probably could have been missed opportunities, and then we make issues of referral. Leveraging again on the existing in terms of human resource and infrastructure, so that we don't have another separate sort of referring these women to another clinic where we used to have the specialized clinic, the so-called CCC, so that we're able to just provide within the same department. And also to reduce issues of stigma, we just realized that within the same department, rather than just saying that PrEP is for key population, is just to say anybody at substantial risk, and here we're giving priority to our pregnant women.
Great. Asante sana. So identifying the barriers and, you know, like constantly addressing them as you move, yeah?
Exactly.
Great, thank you so much. Now, even with all these discussions we are having, I know because we have seen, and even as we engage with communities, there's a question of, will LEN always be there? Like if I need it, will it always be there? Now, we have Unitaid on this panel, and I want to just ask a question, and thank you so much, Jackson. It's good to see you again. So Unitaid has played an important role in supporting access to the new prevention technologies. What is the global outlook for expanding access to the new PrEP options in countries like Kenya? What would be your take on that?
Thank you for the question. First, I must say I'm privileged to sit down with this esteemed panel of practitioners. The first person to receive LEN in Kenya, very well received everywhere. And the people who serve us, thank you. Thank you for the work that you do. Mine is very simple, is to leave you with a message. I will tell you the story of lenacapavir as seen from Geneva, so that to then directly answer your question about what you can do. You know that, to this day we still have 1.3 million infections a year. We have been talking about PrEP for many years. We have good treatments. So prevention has been a gap. We've talked about choices. We've heard the story of adherence. So when you have trial data, as you've heard, that comes out the way it does, sorry about that, then the world takes notice. If we're going to dent this scourge of HIV, then we have to use every tool. So what was the tool? Lenacapavir. What was lenacapavir? A treatment drug, a salvage drug used in the developed world. Very expensive. To give you a sense, it cost $27,000 to get lenacapavir. The lenacapavir you got, someone in the US has to pay that. That's what their insurance system cares for. Anyway, when the evidence came together, WHO very quickly put together, and as you must have heard earlier, on putting the guidelines together. Then the question was, how do we get the product to countries like Kenya, South Africa, and other countries? How do you register this product? You'll be surprised to know that there was a lot of work done with the regulators. Even Kenya's PPB, South Africa's SAPRA, and others reviewed the dossier in Amsterdam with the European Medicines Agency for lenacapavir, for PrEP. Now, Zambia, South Africa, Zimbabwe registered the product within 20-something days. I will not talk about my own country, Kenya, but I hope the message is taken. And with WHO's help, there's the whole process where regulators work together to register the product. The next challenge was, how do we get the product? How do we make it available? And of course, the powerhouses that help us scale up products, PEPFAR, Global Fund, came on board to negotiate down the prices that were there to an affordable price. I don't know what price they got because it's not publicly known, but we know something. We know that it was promised to about 9-10 countries and to treat about 2 million people. And that has been the story to date. Now we have lenacapavir coming, which then leads to the question you're asking. Will we have access? Will we have access to LEN? There are a couple of things happening. The innovator did give away the license to a few generics. There is work that has been done, including by Unitaid, in trying to get a generic version of lenacapavir at price parity with what we have as oral PrEP today. So that helps the people who budget. But here is my advice. This is what I have observed. The conversations globally, both with the suppliers and with the policymakers that support you, ask a very important question that only you can answer. How many people need access to this product? When the numbers are put together, they say, but when we look at the reported PrEP numbers, they are so few. Kenya, treating 1.2, 1.3 million people, is reporting 60, 70,000 people on PrEP. So if you are the manufacturer of the drugs, you're asking, okay, why should I make this investment if I am not convinced that there are people who are demanding these numbers? So communities, please push the government and push those of us who can do something about it. But the government, the policymakers, the people who study these things have to start to put together a very compelling case on what that scale-up could potentially look like. And lead the way, show with your research, with your thinking. You have to show, you have to push. Otherwise, decisions are being made without this knowledge and without your knowing that. So that is what a country like Kenya can do at the forefront of this.
Great, I love that. We can create good crisis, right? And that's what we need to do. We just need to go out there, and anyone who would like to use lenacapavir, we give them. If it ends in a month, it's good crisis, and then we make people like Jackson have sleepless nights to make sure that we get more products into the country. So that's a good problem. Great. I would like to go back to Samson and just ask, what would you like the policymakers and health providers to understand about making prevention services work for the people?
Thank you for that question. So apparently, due to our misinformed youth, we really need to pass them the information. They really need to know this. I just wish, I don't know if it exists, but I just wish that there were like youth-based CBOs who maybe could have gone and talked to the youth. We are counting on youth like from sexually maturity, male or female. They are sexually active at a certain age. Once maybe the government could give direction on the age that maybe the youth and the adolescent can start being talked to, being given this health information, it could really push and go a long way, because as the youth, we are the one who, actually we are really in need of it. According to the norms that are going on right now, according to the behaviors that we are posting even online, sometimes they are unbecoming. But we really need to push this among the youth, because we know that us as the youth, we are going to make the positive, what have you called it? What have you called the positive?
Good crisis.
Yeah, the good crisis.
Yeah.
We are a movement. Gen Z, we are a movement. We are sure we can do this, we can do this, we can change these norms, we can change these statistics, we can change these numbers. Each and every, we know ourselves, we know ourselves better than our parents know us, better than anyone else knows us. So whenever I am empowered, I empower someone else. Maybe I go and empower a school, I give them the health information. I am sure that we are going to have positive feedback, because information, it's all that we lack. The nation lacks information. I'll give you a small example. 1 week after I received the lenacapavir jab, I was invited to KBC, Radio Taifa, for an interview. I got shocked when I entered the building. Like, the producers were like, okay, so you are HIV positive, that's why you got the... Oh, so you don't know what lenacapavir... I had to explain it to them that, no, I am negative. I have taken this because I value myself, I value my life, I value my health, and I value my future. And for that, I want to be on the forefront of pushing this. That's why I took it as a youth. That's why, like, I have never answered anyone who has kept anything on the internet, because I know it might cause speculation, and that speculation might bring negative impact to us. I'm urging and really pushing for information. Let the information trickle down, not only to us, because all of us right now, I am sure each and everyone who is in this room, they know about PrEP, they know about health education, they know about lenacapavir. But what about your kids? What about those children in high school? The ones who are already sexually active? What about those in universities? Like, we have a lot of people graduating from high school, turning 18 years, like each and every year. When we get that population, we are going to make positive. I believe we are going to make positive impact. Yeah.
Right, so we move beyond preaching to the choir, and we go fishing. Sindio? Yes, and provide information. I know Prof is about to leave, So I would like to ask Prof this question, and then we'll continue with the next panelists. So the PrEP space is expanding like really quickly. There are new innovations in the pipeline. So if you could just speak a bit to what should we expect beyond lenacapavir? What's next?
Thank you, Patricia. So I would want to ask the audience, do we need, with this exciting product, which is near perfect, which is lenacapavir, do we still need other additional products? Do we still need additional products? I hear some people even saying no, some saying yes. When I was younger, probably still older than Samson, EVAC took us, that was 20 years ago, EVAC took us through an experience. The experience, and I would still want us to do that, is to look at ourselves, to look at our feet. Do we all have the same shoes? Look at, including the audience. No, we don't. Meaning that we have different preferences. Again, think about ourselves today. In the evening, are we going to keep the shoes that we are wearing at the moment? No, because some of us will go to the gym, others will go to the beach, others will do other things. So what am I saying? That as an individual, you go through different seasons. You are single, you are married, you are young, so all those seasons would also change your preferences. Again, it's not one size fit all for the audience. There are people who will still stick to the old good PrEP, oral PrEP. And by the way, oral PrEP is very effective also. If anybody adheres to it every day, it is still over 99% efficacious. So it's not that we are going to throw away those products. So that's also an efficacious product. When we get lenacapavir, we still have our cabotegravir. All these methods are also good, but they are as good as how you use them. If you keep using them, then they are good. So now, even with lenacapavir, the prevention toolbox is still going to expand to cater for different preferences. And some of the expansions that we are going to have, and we had, for those who attended CROI this year, we had of new products. One of them is that lenacapavir currently is 6 months, and we are told it's given how? Subcute, yeah? But the manufacturers are not sleeping. They're developing an intramuscular cabotegravir, which is going to be used every year. So you get your jab in your back, yeah? That in the muscle, like the old injections we used to get. You get that one injection, you're protected for a year. Is that going to be exciting? Probably even for some people, it's going to be even more exciting than the 6 months. Then we have also heard about the dapivirine ring. Currently, the dapivirine vaginal ring is a monthly ring. The developers are also working to get a 4-monthly ring, so that then you get your ring stays on and you are protected. And then you also have the cabotegravir is currently 2 months. Actually, the ring is actually going to be 3 months. The injectable is going to be 4 months. So we have cabotegravir. They are working on a method which is going to be ultra long-acting cabotegravir. So you move from 2 months to 4 months. And many of us try to engage them to develop a cabotegravir which would be 3 months. Why? Does anybody know how we wanted them to develop a 3 months? Because we wanted it to align with the schedule of the Depo-Provera, the injectable contraceptive. But I think the developers couldn't be able to fit it within the 3 months. So you'll get another 4 months. That's also in the works. Beyond that, we also have a very exciting product, and probably that's where I'm leaving, because I need to go to attend that meeting. It's on the monthly pill. The developers are also working on a monthly pill that you take. It's known as MK. It doesn't have a name at the moment. It's MK8527, and we are working with many people in the audience currently because we have just started the trial. The site that I'm involved in, Thika, has already enrolled 3 participants, and there are additional 3 sites in Nyanza, which have also started enrollments. So soon, if that study shows safety and efficacy, we will have a prevention tool, which is going to be a monthly pill. So you see now our toolbox is filling. So those are the products that are near getting to the toolbox. There are other products that are further away, and I'll probably just mention them because we are with some Gen Zs here. They are very good in Google and searches. So one of them is the broad-range neutralizing antibodies. I would want us to look at those, both for prevention and treatment. There is some movement there. There's also multi-purpose technology product where you get your ARV and you combine it with something to prevent pregnancy, or you combine it with something to provide STI, to prevent STI, or you combine the three. Because we have also realized it's also, for example, when it comes to women, it's the same woman who would want something for prevention of pregnancy and prevention for HIV. So if they get that injection or they get that pill and that protects them against more than one indication, it probably results to higher uptake, higher persistence. So again, those are additional tools. But there are many others that I'll probably not get into, including some that can be used around the time of sex so that you can have your insert and then you can use it both as PrEP and PEP. And finally, as I come to conclusion, is that we are also thinking, and there is also a think tank that is also thinking around PEP. We all know about PEP. Yes. PEP is a prevention tool that has not, whose whatever has not been actualized, whose potential has not been actualized. PEP, so far, we only have the 28-day pill pack. So you take your daily, every day, you take those 3 drugs combined for 28 days. But there are discussions to also develop that space of PEP so that you can either get into a monthly pill or other products. So again, stay tuned. And remember that PEP is also a very important tool that can also be used when somebody has not used a prevention before, can be used post-exposure. Maybe I could stop there. And thank you, and sorry I have to leave you because I have another meeting to catch at some point.
Thank you so much, Prof. Yes, for the insights and also, just whetting our appetite that there is more that's coming. And we do hope that as the country has committed to having at least less than 1,000 new infections by 2030, that all these products will move us closer to that target. Thank you so much. So I just want to ask one more round of questions and then we get to the audience so that they can also have an opportunity to ask questions to the panelists. But connecting very closely with what Samson just said, Solo, I would like you to speak to the role of community-led organizations, what role they play in ensuring uptake and continuity of prevention services.
Thanks a lot, Patricia, for that. And for me, this is now broadly key populations, larger communities in terms of the uptake. I think for me, as communities, we play a critical role in terms of the uptake because if you look at the key population program, it's heavily preventive. So as key populations, we are saying that, yes, we play a role in prevention of HIV. And I can actually add that as communities, we need to be in the spaces whereby we are actually looking at the response. I know as key populations, we have been engaged in terms of the development of the guidelines, So can we move a step higher in terms of, rolling out, how best do we implement the guidelines? As communities, we need to ensure we are there. The other thing is, I think for me, peer-led services. As communities, we know where our people are. Yeah, we've just had an example of the AYP, our young people, Gen Zs. Yeah, KPs know where KPs are. Communities know where communities live. So I believe a peer-led model is still very crucial in terms of the response, and it is actually led by communities. Then the other thing I believe that communities get engaged is something called community-led monitoring. This is whereby, as Solo, I go to a healthcare center and then actually say my experience. How did I actually receive the service? This is a strong voice, from communities. And I believe as counties and also our development partners, this is very crucial when it comes to getting the community feedback in terms of access. Then lastly, I believe, as I'm talking about opportunities, right now we are in between. Moving from donor funded to community funded to government funded or supported. So for me, it's how best do we actually do social contracting? How do we do domestic resource mobilization? Yeah, right? So that we are able to sustain the gains that we have actually done.
That is well said, and I just want to transition back to the county after listening to the feedback from the communities. So what support do counties need from the national program and partners to sustainably expand PrEP access?
Thank you. As a county, I think what we can do, rather than just talking about the K-pop community, we need to go back to the community strategy and leverage. How can we build the capacity of the CHPs such that we'll reduce issues of stigma that this PrEP is only meant for this category of group. So by doing that, I believe having a curriculum that would be used to train the CHPs would be really grateful. The other thing would be issues of, we've noted that as community go out, they'll be doing demand creation. Then if you have an interrupted supply of the essential commodities, here we are talking about test kits, we are talking about drugs, then it will ensure that we've had confidence and we're able to provide services to the clients at any point they need. Then we also need to have a way that at the national level, then we need to have updated guidelines in terms of any new policy or any new directive coming in that needs to be disseminated down to the county level in terms of capacity building of the TOTs and ensuring that even adequate resources are mobilized to ensure that there is continuity of dissemination now that we are having donors exiting. So how do we ensure that we need to roll out? Because previously it was national bringing it to the county, then it's the partners trying to scale it up. I think that one would be okay. Another thing would be issues of, we've talked about the data systems. Currently we have multiple data collection or EMRs that are not really talking to another. So if you have a system that would be talk about being interoperable, then it would be really great such that we'll be able to pick. Last but not least would be in terms of availing adequate resources to ensure that especially big counties that talk about the cities where you have the private sector, because again, they do have a significant number of clients that do access. Then how do we actively bring them on board and ensure that we have an interrupted supply or strengthening our supply chain management that we ensure that once drugs leave, it's not only from KEMSA to public facilities, but KEMSA to a private institution, let's say Mombasa Hospital, Pandia, and that one would really be okay.
Wonderful. Very key issues that you've highlighted there, from commodities to engagement at community level, ensuring our data systems are speaking to each other. Very, very important. I want to come back to Dr. Were, who spoke about the community delivery approaches and also the pharmacy. What are the key policy or regulatory changes that are needed to scale this community delivery model sustainably?
Yeah, thanks. So I think the mantra underpinning a lot of this work around expanding service delivery models is really how do we make PrEP easy to find, easy to start, impossible to ignore, but also ensure it is delivered safely. As the evidence becomes available, we also identify several policy gaps that need to be addressed. One is around the scope of practice. For instance, if we are to expand delivery for PrEP to pharmacies, and then there's a question about the scope of practice for pharmacists. And there's been a lot of work happening in that space with the regulator, that's the Pharmacy and Poisons Board, towards the good pharmacy practice guidelines that will address some of those policy gaps. There are also issues around the levels of care for services, particularly the Kenya Essential Package for Health. And essentially there's also work in that area towards classification classification of pharmacies within the different service delivery tiers. Certainly also there is issues around a framework to guide the public-private sector collaboration. Glad that NASCOP advanced this through the private sector engagement framework, but also in terms of service delivery guidelines. Of course, we have the differentiated service delivery guidelines that were launched about 2 years ago, and we are looking forward to the integrated HIV prevention treatment, STI, and viral hepatitis guidelines to provide also further clarity around some of these delivery models, including simplification of HIV testing through HIV self-testing. Yeah, thanks.
Thank you. Back to you, Jackson. So the question I have is, based on the lessons learned on our previous product introduction, how can we ensure that there is equitable access and sustainable delivery?
That's a loaded question. And I don't know how to answer it, but I think about things very simply. First of all, let's be clear. You know, if this was a dolutegravir introduction, that's easy. You are changing one drug, the people who are taking the drugs are there. You're not innovating. It's, you switch it, you just make sure there is enough money, the FNQ works, you have plans with the Global Fund, PEPFAR, and you turn the switch and you get the product. Now here, you have to build things ground up. And just earlier, I spoke about how in my humble way, I have observed how decisions are made about you that you're not aware of, particularly about what the need is. You have to define that need. And I think if we can learn from WHO in a simple way, for example, they do guidelines. Now they have said they don't want to be bureaucratic about it. They want to learn as they move. So they have living guidelines. They can change every day. They don't have to be printed. Why can't we, at every level, within the communities, the youth, the counties, be clear about our priorities, communicate them? Our government partners, we should have a model that says this is how we are scaling. There should be no donor that comes into this country and says, I only have 50,000 doses for you. You should say, this is my need. This, and I can define it. I can define how we get to scale. And it's founded on experience. In this room, there are people who've been doing this for 20, 30, 40 years. You know how to do it. I'm afraid, I tell people this in Geneva. I don't know that there is any country waiting to be taught how to do PrEP. I don't. Not sitting in Geneva. I say it openly myself. So, but you have, unless you communicate, you are clear about what your needs are, what your priorities are. You inform the policy-making process. In fact, if you look at some of the PrEP guidelines done at WHO, I have seen a chair from Kenya. So what are we waiting for? We have to do it. Last point I want to make. You heard about MK8527. The trials are happening here. You heard Professor Ngug in Uganda and in South Africa by one of the innovators. The innovators are working on a new product based on your experience. I will tell you what we are doing. We are demanding, or at least I'm demanding, in the little role that I have, that these products, both a high-quality generic and an innovator generic, and the innovator product become available at the same time. We hit the ground running. We should not be in the business of being told, step on the brakes. No. But, like I said, we have to be organized on our end in clearly articulating what those needs are. And that's why everyone comes to Kenya. You have the data systems, and you can build on them. You have everything that requires. You have the expertise. You just have to start to make these demands, and I'm willing to help you in every case. We want to go as far as that the generics, high quality, WHO pre-qualified products can actually be manufactured on the continent of Africa. It's not a joke, it's serious. These conversations are happening now. So it's your turn now to drive this over.
Wow, you get the challenge? Yeah, so we have to keep running until we get to the target, but also that we have to define our need so that anybody that comes, we present the need and we are able to negotiate. So I would like to come to the audience before we do a wrap right here. Anybody has a question to ask? If you could just lift up your hands, and I request one of the Gen Zs to come and pick the mic. You know, they're strong and they move very quickly. If you can just come and, thank you, get the mic, and we can start this way. Please start with Prof right there as we go.
Thank you, and good afternoon, everyone, and very nice to see Jackson and the team up there. Yes, and Kissinger. Yes, we go back many years. Now, you're looking for people to take PrEP. I pose to you, and this is based on my many years of working in this field. Every person living with a partner who's HIV infected is at risk of HIV infection. And the reason for this is that drug adherence is a very difficult thing. And people will adhere and then stop. So maybe that is market number one. Partners of people living with HIV. They are a direct, this is direct risk group. Now, when you talk of key populations, there's another group that we have forgotten, we don't no longer talk about them. And these are individual, they are part of that partners, the discordant couples. Since we started saying you equals you, people have stopped disclosing their HIV status to their partners. And I'll tell you, the people, the health workers here, we have a crisis every so often when a child is tested, we mean I'm positive, dad shows up and it doesn't look like there's a big deal. So clearly there's been a lack of disclosure about status. So that's the other group. And then of course, we must develop pediatric formulations. Babies need to breastfeed, and breastfeed for 2 years. And even if mom is taking her drugs, many times they stop taking medicine. Many times they'll have a crisis and miss drugs for a few days, and that's when the child gets infected, right? So I think we need to go back to the drawing board and do some modeling, good mathematical modeling to help us identify these populations. This is what we did in the past, and we can do it now. I think we have more expertise in this modeling without having to wait for somebody to come and model for us. Yeah.
Great, thank you so much, Professor. Let's move to the next person, and please let's ask one question each, so that we give the chance to others also.
Okay, thank you so much. I'm Navros D'Souza. I'm very proud of you, Samson, for being brave and taking the jab. And then maybe to answer Prof. Ngure's question on do we need more, I think the more the merrier for young people. So if we can get more choices, the better. Now my question will go to Dr. Were, just to ask, because we are still at 41% in terms of new infections among young people, and we are at 4 choices. We have the ring, we have the pills, we have CAB, we have LEN. And we have 41%. So are there lessons that we've learned, the hits and the misses, from the 3 other methods that we can borrow with LEN, so that we're able to target this 41%? Because yes, we tend to believe that LEN would be a game changer for young people, but we have other methods that have been there, yet we are still at 41%. So are there lessons that, from a delivery point, I think from a research point, we've seen that since 2015, the time has been shorter. However, from demand creation and from an implementation phase, are there lessons that we've learned that can help specifically the young people that we are supposed to target with this lane and these other PrEP options that will be coming in future? Thank you.
Yes, let's take the last question this side and then we'll come this way.
Thank you. My name is Richard. I work with AVAC. First of all, I would like to congratulate Mutua for that particular courage, and of course also speaking to the young people, and of course also showing exactly the next phase of the whole issue about the need for prevention. Now, I wanted also to ask a question to Unitaid, and this particular question, yes, this particular question is, at the moment we are discussing about availability of LEN on market-shaped prices. Now, let's basically, and of course countries are now moving forwards to planning. And of course, we are talking about, of course, the increase of domestic resources. And of course, we know exactly also from the allocation letters this week, some countries are already moving out, of international domestic for health. So what is it exactly in terms of countries' preparation? I know, of course, at the moment, countries are looking at those particular doses that we have received. Like in Kenya, for example, I don't know if it is 20,000 doses. But what happens is the fact that in any case, if at all, let's say we are to move, of course, we are talking about generics. Do we have a clear sense of how much the generics will cost? And of course, how much would basically should our ministries be prepared in terms of allocating to this particular instrument? Thank you.
Thank you very much. So I will turn to the panelists. So Justo, you can just come and stand now on this side. But yes, to the panelists now to respond, I think we have two questions. What Prof. Ndwati said is, like adding to who should we target, and of course raising the concern around pediatric formulation. But Dr. Were, so what lessons have we learned, both from the demand generation and service delivery side, that can help have the young people use the PrEP methods as they come?
Yes, so thanks for the question. So I would say, I think there's a lot that we have learned now, and we really don't need to reinvent the wheel as we think about how best to deliver not only LEN, but also the other existing products and products that will come into the future. I think number one, in terms of demand generation, there's a lot to learn around messaging. And there's a lot of work that has been put in terms of research, in terms of human-centered design to co-create with young people to understand what they want and how best to message. So there is a question about how best we message. I think risk-based messaging does not work for young people. I think that's something that we have learned. And also one of the main lessons we really learned around demand generation for PrEP is that really PrEP use, especially for young people, is very emotional and it's relational. It is more about possibilities and needs for the individual that go beyond just risk and HIV prevention. So if PrEP is appropriately positioned in terms of demand creation messaging within that framework, then it is easier to get more young people to come for services. And we've done a lot of work around that, and there's evidence supporting that. Two is around service delivery. How are the services delivered? Because I think at times there's a challenge of coming up with a delivery model that is convenient to the health system, but inconvenient to the client. So that is something to think about. So how do we design service delivery models that essentially resonate with the needs of the client, and you meet them at a point that is convenient for them? So I think those are like the two top level key takeaway messages I would give.
All right, and to Jackson, you've got the hard question also. Do we know how much the generics will be charging for LEN? And yeah, what would be the expectation in terms of what the governments can put in?
So that's a good question. But before I come to it, I think I want to echo what Professor Nduwati said. If you want to see these PrEP products at scale, it means that somebody has to manufacture them. They have to be able to sell. So we have to be able to expand access to those who need it. So we have to define those populations. We really must, and we have to quantify. We can do the models. They can be living models. Be the first, Kenya, be the first to do it, because no one has done it. I have been in meetings with suppliers who say, okay, we have to build a factory. For whom are we building it for? Is this just a sunk cost? Can we make it work? Unless you can grow the demand by defining what that demand is, you also cannot convince the Global Fund that, you know, that your quantification is credible and that the funding you're seeking should be given, particularly in such times. Now, back to your question. I think there was a recent announcement, I think around the UN General Assembly time, by UNITAID and one of the generic suppliers who had received a license from Gilead. And the price set, announced publicly, you can Google, is $40 per patient per year. $40 per patient per year is essentially, and I think the number was, there was a rationale behind it, which was to ask, okay, what does oral PrEP cost today for a year? TDF3TC. It would be roughly that same cost, $40 per patient per year. So it was determined, well, if governments are planning to use this product as one of the options for PrEP, then it's comparable. There's price parity and you can replace one for the other, assuming that the supply follows. So that's happening. And as I mentioned, there's a lot of effort taking place right now to manufacture these products, including here in this country. And that's why I'm here this week and next.
That's good.
Yeah, we were all excited to hear that one of the manufacturers are here in Kenya. So shortening, the cost in terms of even transport, to be very easy to get it to where we need it to be. So on this side, we could take maybe some 2 questions, and they are all at the front here. Karibu sana, Dr. Mulwa. Thank you.
Thank you so much. My name is Benson Isaboke. I'm here to represent persons with disability, most of the key populations that have not been mentioned. When we talk about, we have not talked about men and boys, more specifically in HIV programming, who we are mostly known as perpetrators, which is very key. And my question actually comes directly into terms of the presentations that we saw here. There was a launch of a testing guidelines, and we never saw anything related to persons with disability. How are we going to do testing without involvement of persons with disability? And disability is diverse. We have a number of persons with disability with their own way of understanding. Kindly, can we be informed how we're going to target such a population? Number 2, the representation from WHO. We are cognizant, like each and every country, it has 16% of the total population. As a country, we have no facts how many persons with disability we have. In HIV programming, can we be able to have exact data also that can be anchored or reflected so that we also persons with disability can be targeted with a specific percentage, if in any case there's programming that is coming to the country, and as a population to have the intervention. As by also the report the ministry gave, there is a clear gap of exclusion or representation of persons with disability with the challenges or the gaps that we saw from here, which the first key, we have attitudinal barriers. If a person with disability is coming with a wheelchair, as a person who maybe, for example, want to take the PrEP, or a person who has been infected or who seeks the service, have we empowered the service providers? Have we trained them about disability etiquette? How to accommodate persons with disability in service delivery? Even the access of the facilities, are they accommodating us to come in and actually get the services with confidence? And the privacy is very key. We have our friends who use guides or aids. If a deaf comes to our facility, how can you make the information private? Have we trained our health facilities sign language? If a VI, for example, somebody who is not seeing is coming to a facility, how can you break the results to that person? Lastly, there is an aspect of integration. There are those of us who are positive, who has been affected with the condition. To an extent, they have disability. Which process that do we have to bring them to our systems, also they can be able to benefit from many assistive devices that are from the disability sector? Thank you.
Thank you very much. We can take the last person.
Good afternoon. Good afternoon, all. Good afternoon. Thank you for inviting us here. I do not want to speak more. My name is Joseph. I am a deaf person. And I will be general. And I want to talk about today's theme. Health without barriers. And this is the question that I want to give to you directly. As a country in Kenya, they launched about the LENA. How is it inclusive to the PWDs? We have our organizations, LVCT health centers, and they have PWDs who are using PrEP. And they are there. But during this launch, why didn't you include them? About the policy. The second question about the policy. The WHO guideline and the regulations must have progress with PWDs. LENA, during the launch, there was no even sign language interpreter. How was this inclusive during the launch of the LENA? That is the second question that I have to ask you. Thank you.
Right, thank you so much. We are running out of time, so you will allow us just to respond to those questions, please. And if you have more, please just write them down. We will be able to take them and see how to respond. But I think a lot of the questions that have come from persons with disabilities is basically just challenging us in the HIV programming, that we need to be inclusive. And I think for the first time doing the IEC materials, we have one for persons who are visually impaired, and we are continuing to develop more to also be able to accommodate the others. We take the challenge on breaking down the data to include persons with disabilities, and to ensure that our materials can actually speak to the needs of persons with disabilities, and also that as we do trainings or sensitization to the providers, that we also ensure that there is some level of understanding on the Kenya Sign Language. Did we get you right? Yes, and then for integration, I think addressing the same thing, that our integration must be responsive to the needs of people with disabilities. So as we close, I just want to give each panelist just a second to say one thing on how we are going to make sure that the people who need PrEP are getting it. Those who need LEN are getting it. Just one thing. Don't say and. When you say and, I take the mic.
Simplified.
Joint.
Access.
Start. Information.
So that marks the end of the panel, and I hope we all enjoyed it. As we close it, I think the one thing is, let's create good crisis. So thank you so much, my panelists, for this amazing, amazing session. And we're just going to take a photo as we transition to the next point. I think it's Wawera and Lennox coming. Yeah. Or let's stand and take a photo.
Okay, thank you very much, panelists. I think it was a very exciting session, very gender imbalanced. We had full men on the deck, and Patricia, who managed them very well. Anytime you want something to happen, you put a strong woman in the front. So we have our final comments from Wawera and from Lennox. They are just going to wrap up what the session was about before we hand over to Dr. Mulwa, who's going to address us.
Thank you very much. And what was I supposed to do? Wrap it up. Thank you for the opportunity to bring it all together. That was an amazing session. My name is Wawera Nyaga. I'm the Executive Director for Health Market Access Bridge, or Access Bridge. And what we do is we catalyze, everyone, partners, information to ensure that all these things we're talking about reach the intended beneficiaries, or people that could benefit from using PrEP in the most equitable and speedy manner that we can. But I'm very privileged to be with my young Gen Z here, Lennox, and he's going to summarize the session with me. So I will start just by giving a quick overview in terms of what we heard from the first presenters. So Dr. Eunice very kindly, shared with us the global perspective. But then even as a country, we operate within a global realm. So just so that we have confidence that we're not doing this alone, we are guided by global guidance, and that we are aligned also with other people what they are doing. So what we are seeing is globally HIV prevention coverage still remains low. So we are not the only ones as Kenya to wengi. But the good thing is that the science has really advanced and it's favoring us. Beyond what we had previously, we have a wide product portfolio. But then also what we had is that prevention choice options is not equal to choice. So we need to do everything that is possible to be able to translate those many options that we talked about. And we talked about what? Pills, we talked about ring, we talked about injections, and we talked about two specific ones, CAB and lenacapavir. But that does not translate into choice. If people that need to use those ones cannot access them, where, when they need to access them. And many things need to happen. And the good thing is that as a country, we have many models that we are testing, you know, and that means we can be able to reach the communities at a place where we know we need them. But then we need to make sure that we have policies that guide in ensuring that the differentiated service delivery models are favorable so that those services can be reached there. Then I heard about Kenya. We have made very strong progress in HIV treatment, but prevention remains critical. And we are fortunately amongst the pioneers in this continent. And it was very exciting last week, but when we joined the global community as the 4th country, you know, to launch LEN. So big up Kenyans. So we are still leading the way. And so I'm going to hand it over to my colleague, just before I go there, before I hand over to the Gen Z. I think I've talked about options, need to, you know, translate into choices. We have models that have been talked about, the community pharmacy and, you know, private delivery. We've talked about long PrEP delivery mechanisms, helping address some of the issues that have been a key barrier, especially in terms of, you know, regularly taking and also some sense of stigma. But then also we need to ensure that, like, you know, the last panelist talked about, that even as a country, we are creating the demand. And Patricia said that we need to create a positive crisis. So I'm going to hand over to Lennox. Lennox?
Thank you so much. My name is Lennox. I'll pick it from good crisis and information. That was the last word from client 0 or client 1 as he's referred to. So basically one of the challenges that has been pointed out is the challenge of inclusion, especially from the key population. That was number 1. Number 2, we had an issue of demand creation. And by the way, this actually provoked my mind. Why do we, there was an issue of messaging, and this actually came out. Why do we struggle to create demand for PrEP, and for PEP is relatively easier? So basically there's an issue of demand creation and the issue of inclusivity. So basically prevention must be client-centered and delivered where people prefer them. So key population, youth and men prefer flexible serving points. Men in the room, key populations, youth and men prefer flexible serving points. Someone said men have normally been normally we've been taken to be the perpetrators, and that need to change. So integration with SRH and MCH and primary care reduces stigma for HIV. What are the key barriers to scale up? 1, we have stigma to access points, donor transition to sustainable concerns, commodity and supply chain gaps, fragmented data systems, policy limits on policy limits, lower reported PrEP demand affecting supply. So basically that was the point, that if we really want to get PrEP again, we have to create the good crisis, as said by Patricia Jekonia. So basically, what am I trying to say? I'm saying strong systems, policy support, and financing are needed for proper scale up. Lastly, what is our call to action? We need to expand access, strengthen community role, plan for sustainability. More importantly, we need to create demand. Thank you so much.
Thank you very much. And before we hand it over back to Dr. Barbara, please, Dr. Barbara, come in front. I think you've seen some people sporting very beautiful t-shirts. Doc, what does yours say?
Oh my. I can't read it on me.
Let
me read his.
Okay.
Rada ni prep rieng ni len.
What does that mean?
I don't know. I think I'm not the target.
Lennox, please, for the old people in the room like myself and Doc, what does that mean? Rada ni prep rieng ni len.
Rada means like the plan.
Yes. So basically, Rada means this is the plan. Rieng ni, like how we doing it. So Rada ni, yes? Absolutely, the vibe. So PrEP is a new vibe for the young people. Thanks to NASCOP, thanks to Government of Kenya. Thank you so much.
Doc, I can read for you what yours means.
Okay.
It means you can peel it, you can ring it, you can cab it, you can lend it. Chaguo ni lako.
Yes. So this is choice.
And me?
Stay there. I want to speak as a grandmother and as a mom and as a Kenyan. And I want to challenge this generation that where are you in creating the new products? How are we investing in your skills so that you're the one who is creating new products and taking it to the rest of the world? Right now, we are focusing on being recipients of what has been prepared by others and who construct what we should be based on their understanding of who we are. I want to see your generation there at the university, in Cambridge, in new research institutes, creating a solution. I think I've said enough.
Thank you so much, Prof. And I'll make a comment on your question after Doc.
Yours?
Yes.
Shoti moja kila miezi sita supu. Usipate HIV jiprep na len.
So 6 beautiful months. I think that is very clear. And I do agree with you, Prof, when you talk about engaging the young people way in advance when these products are being developed. I think last year, before things changed, yes, and there was an initiative, actually. There was one project that was called Matrix, and I'm sorry that Prof left before he talked to more about what was happening. But unfortunately, when there was the stop work order came into place, that project died. Oh, about them.
Who of these partners are putting money to take these kids to school, to university, to be molecular biologists, molecular scientists, pharmacists, to create the new drugs? Who's doing that? They tell you, Mr. Hongo, you're my friend from a long time ago. These companies are making huge amounts of money, profit, from you using the drugs. How much of that is coming to develop you? To develop you, to be the one to develop the drugs that suit your body. And to prevent infection to the next generation. How? I think that's a question, that's a discussion we should be having. This is a new, I would use the word colonialization carefully, but it is a problem. That's why now, stop work order, we're in trouble. If those 20 years of funds was also developing us, supporting drug production, when the people walked away, would have said, thank you, you helped us, we are moving forward. Right?
Yeah, that is true.
Yes. I see the youth nowadays, they say, clock it. So I think Prof. Nduati clocked it. Let's all say, clock it. Clock it, Prof. Nduati. And thank you so much. This session has been very enlightening. We already listened to policymakers, we listened to the people on the ground, the counties, we listened to client one who was brave enough to take on the LEN. We heard what our feedback was, and at the end of the day, we have to create a what? A good crisis, one that suits us. If they're not going to call us to the table, we will demand to be on the table. So my appreciation to everyone and everyone who managed to sit through. I know today wasn't easy. There was probably lunch, no lunch, I'm still not sure. But thank you so much for bearing with us. I would like to, at this point, invite Dr. Mulwa, Head NASCOP. He joined us towards the end of the session to give us a word before we close for the day. Karibu sana, Dr. Mulwa.
All protocols observed, my professor, my teacher, Professor Duarte, all colleagues from the communities, our sponsors, our partners, colleagues from the ministry. I think partners are in their numbers. I may not recognize all of you. Today is Sunday, lest we forget. And Sundays usually are days that people are off work, and we are here discussing very important issues regarding the HIV programming. Today's session was talking about prevention, and I got in and got out and came in towards the end. And I have had very rich conversations and thought-provoking conversations coming from the panelists, from the delegates who have asked questions, and Prof challenging us to question the status quo in terms of where this part of the world continues to be, in terms of being recipients of what has been developed elsewhere, which is a good challenge. I think I am already starting to feel excited that the purpose of this 4 days, actually 5 days, counting today, summit will be achieved. I think it has been a year since we last, we had the stop to work order. And I remember very well, on the Friday before the Tuesday of the stop to work order, I had called all the HIV stakeholders at our hotel in Nairobi. I had just been appointed the head of NASCOP, and we were in celebratory mood that this is how business will run, these are our plans, we had a Ken Fear, we had what things that we wanted to do last year. 3 days later, the stop to work order came, and we had to reboot. I think after 1 year of rebooting, there has been new developments, there have been new innovations, new approaches to issues, but the most important thing that we have done, we have continued to run the HIV program and sustaining the gains that have been made over the last 20 years. Some of them have worked well, others have been misses. We are here to have honest conversations with ourselves, with our partners, and share experiences from delegates from other countries that we have invited, Tanzania, Uganda, South Africa, Angola, and we hope that they will be here to share their experiences because they also went through that. Within the same year, a lot has also developed. Despite the stop to work order, the US government has come in a bigger but a different form. And that is how do we optimize that opportunity that comes in the coming years so that in 2030, 2031, we don't find ourselves where we were last year. I am not dressed for official business. A lot of you know me in a suit and all that thing, but I am also like this over Saturdays. I am a Manchester United fan, and our game begins in 10 minutes. And I've watched all my new games from 2002 to date. I'm not about to miss the next one. So pray for us. So I think tomorrow we begin the sessions. Kindly for registration, and a lot of you have done registration today, please be here between 7:30 and 8 so that we do the registration, so that by the time our chief guests come at 8:30 or onwards, we are all settled. We hope to handle your logistics. Please be safe wherever you are staying. Make sure that your security is paramount, because we are now a family for the next 5 days. It is my responsibility to take care of each and every one of you for the next 5 days. So make my work easy. We have young people, we have older people, we have enjoy Mombasa, go to the beach, but let's be safe. Let's be in the sessions. Tomorrow we will be guided in terms of where we'll be. Tomorrow will be a plenary. Then we'll have breakout sessions so that we can align ourselves with our various interests, and we value the contribution of each and every one of you. We had anticipated to have 500 delegates. The last record I have, we are close to 700 delegates who are already registered. So not oversubscribed, but that tells us the amount of interest that this summit is generating. And that therefore is very exciting for us. We hope to have to handle your logistics for the hotel. We hope to meet the expectations of all of you when we leave here on Thursday, and we'll have firm action plans that we will be able to say these are the action points that we have agreed on that will change how HIV and health integration is done in this country. Thank you very much for creating your time to be with us. We are together in this for the next 4 or 5 days. Asanteni. Did I welcome you to Mombasa? On my right, there is ocean. The next land mass is India. So please also take time to breathe air from India, from the ocean. Don't just come for the session. Enjoy Mombasa. Mombasa Raha.
Okay, thank you very much, Dr. Mulwa. Karibuni Pwani. I guess we are released for the day. Tomorrow, please come early, especially for purposes of our registration. And I guess we can have, Patricia, can you please pray for Manu and close the session?
I don't watch football, but I do have boys in my house, and so today I know it's going to be fire. I have Manu and Arsenal people in my house. So, yeah, but let's be upstanding and pray. Father, in the name of Jesus, we are so grateful for your loving kindness, for the gift of life, and for the far that you have brought us. Thank you for a very fruitful meeting that we've had today. And we continue to pray, Lord, for your guidance to know how to reach the people that need all these products that we have so that they are able to prevent getting HIV infection. We pray, even as we part ways right now, that you will go with each and every one of us. Grant us your safety and peace as we are here for the next 4 days. The Lord, each and every deliberation will be for the good of the people of this continent. We pray for courage to even do the things that we've never done before. The courage to go out of our comfort zone and ensure that each and every person is reached with information and with services. When we meet here again tomorrow, even with other people who are still traveling, we pray that you grant them journey mercies. As we go out for various activities, some are going to watch football, others are going to have fun. We pray that you grant the desires of our hearts, and that tomorrow we meet here and we will be so grateful for your doing. In Jesus' name we pray. Amen.
Can I invite the panelists, please? Dr. Were, can we all just come here for a picture? Musitoe t-shirts. Dr. Omesa, we come here. Yeah.
Nous allons
Can we just stand for photos, please? Twendeni. Kissinger.